Oh, sorry. There we go. Right. Good afternoon, everybody. Welcome to the South East Maternity and Neonatal Autumn Learning and Sharing webinar. If you go to the next slide, please. You're all very welcome this afternoon. So please remember, unless you're speaking or asking a question or making comments, keep your mic on mute, raise your hand, ask any questions or make comments. It'd be great if you could introduce yourself at the same time as well. And you can also share your comments and reflections via the Teams chat. We'll be recording this webinar and it'll be shared on our Futures page, but also on our South East Clinical Networks web page. So this month, actually tomorrow, marks World Patient Safety Day tomorrow. Sian, could you move to the next slide, please? Thank you. And the theme this year is safe care for every newborn and every child. We know that from pregnancy through birth and the early days of life, safety has to be at the heart of care. Newborns are especially vulnerable, and the health of mothers and babies is deeply connected. A single safety incident during this critical period can have lifelong consequences. So this year's theme, Patient Safety from the Start, reminds us that protecting babies begins with protecting mothers. Also takes teamwork, so families and healthcare workers working together, communicating clearly during handovers and referrals, and spotting risks early to act before harm occurs. I would just like to say, on behalf of our whole team here in the South East Maternity and Neonatal team, we'd like to just take a moment just to say thank you to all of you for all of your ongoing hard work, passion and commitment to improving maternity and neonatal safety, whether it's through the 3-year delivery plan, Saving Babies' Lives Care Bundle, or other initiatives. Your efforts are really making a difference, and we really value your commitment and looking forward to continue working with you as we do this together. So hopefully we can together ensure that maternity and neonatal care is as safe, personalised and responsive and equitable, giving every baby the best possible start in life. So if we can move to the next slide, we've got 3 fantastic speakers for you this afternoon to really showcase the brilliant work that I've just alluded to there. We're going to hear from Michelle at Medway, who's going to talk to us about reducing induction of labour delays and their quality improvement project there. Then we're going to hear from Catherine White, one of our Obs and Gynae registrars, on the decision to delivery interval improvement work that they're doing. And then finally, but no means least, Amber from Oxford, who's going to, and the Health Innovation Network, Wessex, who's going to talk to us about the Early Breast Milk Project. We look forward to seeing you present all of those. So without further ado, I'd love to introduce to you Michelle Keeler, who's a consultant midwife at Medway Foundation Trust. Over to you, Michelle.
Hello, good morning, good afternoon actually. Thank you for having me today. I'm just going to share my slides. Can you see that okay?
Yeah, perfect. Thanks, Michelle.
Okay, so I've been asked to talk to you today a bit about a quality improvement project that we've been running at Medway Hospital in Kent around our induction of labour pathway. This was a great issue of concern in our maternity unit. I'm sure it's a challenge in many maternity units. Our project started actually 2 years ago and has been a work in progress in different phases. Our induction of labour pathway was coming up as being a cause for concern from all different directions, from patient feedback, from staff feedback, experiences of long delays impacting experiences of inadequate communication and conflicting information about risk as well. So we decided to focus on this as a quality improvement project, and it was one of our key drivers at that time and remains so. Just as a little bit of background, Medway Hospital has about 4,500 births a year, an induction rate of around 30%. We looked at the reasons why, reasons for most of our inductions, and actually 25% of our inductions were for induction for reduced fetal movements at term. So that is a very high proportion of our inductions, and that's one of the indications that's difficult to plan for in advance, and that was one of the challenges in our pathway. Alongside some other reasons, those urgent inductions accounted for about 40% of all of our indications for induction, which, as I say, posed some challenges with prioritising. And at the start of the project, we were just looking to make a change in our induction of labour guideline to bring it in line with NICE guidance to offer induction of labour from 40+7 for post dates. And we recognise that that would have some further implications for our induction of labour pathway. So what did we do? We did some work with our Trust Improvement and Transformation team to set this up as a quality improvement project, and we started with a process mapping exercise where we involved staff and service users in mapping out how the pathway worked at the moment, and that was actually a really useful exercise. We thought we understood the pathway well, but different things came up through that process, particularly around the points of contact with the service users, and also some of the administrative parts of the pathway that and how they were actually working in practice that were really sort of illuminating for where some of the issues were. From there, we put together a root cause analysis and had a think about which were the things that we could start our focus on, and came up with some countermeasures to try and see if we could address these key themes that came out of the process mapping exercise. So this is just a summary of some of the things we did. One of the biggest concerns was the limited oversight of the pathway. Our induction of labour pathway was sort of organised through our antenatal ward, but there wasn't a particular person that was responsible for that. It was the staff that were on shift each day, and that meant that there wasn't sort of consistent oversight of the pathway, and different decisions were made day to day with changes of staff each day, and that also impacted the conflicting information that was being given to service users on the pathway. So we managed to secure some funding for a 6-month secondment to for a Band 7 midwife to lead the pathway, and they worked alongside a lead obstetrician. Unfortunately, she's sunning herself on holiday today, so she's not here with me. We looked at our reasons for induction of labour, and we benchmarked our local guidance against national guidance, Saving Babies' Lives, and various other RCOG and NICE guidance, so that we had more consistency in the pathway, because prior to that, depending on who people were seeing, there was variation in when and if induction of labour was being recommended. And we also looked at providing a target range for induction rather than a specific date, and I'll come back to that a little bit more. We looked at the practical elements of the pathway, about how we organise the booking of inductions and our induction of labour diary. We have a list each day now of all of the people that are on the induction pathway, and that includes both people that are in the unit having started the induction process, and people that have reached their date or their range and are due to come in, and we're making every effort to bring them in as soon as we can. And that list is shared across all the wards on the unit and is reviewed at our twice daily huddles, so that we have a clear oversight of who is on that pathway and the clinical priority order at that time. We've also done some work on an induction of labour escalation pathway that sort of feeds into our times of high activity and acuity on the unit, because we'd really found that the high number of delays around induction had really become quite normalised, and the risk that was posed by those delays wasn't creating the amount of concern that perhaps it should have done, because it was happening every day. So we've done some work on that, and we've then since come back to that more recently. And then we looked at the communication with women and birthing people on the induction of labour pathway, and how we could improve that communication, both with them directly and also in the development of some resources. So we had a lot of think about what we were going to measure. when we talk about induction of labour delays, there's actually a number of parts in the pathway where that delay might happen. It might be delay coming in for induction. It might be delay once the person has come in before the induction is started. It might be delay at a later stage when they're perhaps waiting to go to delivery suite to have their waters broken. So there were multiple points in the pathway where delays could occur. And sometimes I think that makes it difficult when we're making comparisons between units about our induction of labour delays, because we're not necessarily comparing like with like. Our priority at this point was about trying to reduce the delays in bringing people in to start their induction, because that's where most of our problem lay at this time. So we decided to focus it there, and we used the list of women on the induction pathway each day as a kind of measure for that, because it was an indication of the flow of how well the pathway was working. The more people that were on that list, the less well the pathway was flowing. When people were coming in for induction and then moving through the pathway as they should, and the next people coming in the next day, then the number of people on the list should remain low. So that was one of the things we measured, and whether or not people were having their induction commenced within their target time. So this was some of what we achieved. So we, at our starting point back in May 2023, we had an average, this is quite embarrassing to say, an average of 18.6 women on that list each day. So that means that there were some days that there were 25 people on that induction list, and we really had lost control of being able to make sure that we were prioritising people effectively. We set our target for the number of people on the list to be 12. That was based on the fact that we usually have about 5 women coming for induction each day, and there might already be other people still within the antenatal ward as part of their induction from previous days. So we set it there, but that was sort of a number sort of picked as an estimate. And through those changes we made, we were able to see a significant reduction in the number of people on the list quite quickly, and that came about with those changes to how we were organising the pathway, as I've mentioned. So during that time, up until the end of December 24, we were able to halve the number of people on the list each day, even though there wasn't any reduction in the number of people having induction within that period. And we also looked at whether or not the inductions were being started within that target time, with the target time being the time frame in which the induction was planned, or within 48 hours if that was an urgent indication for induction. And we saw that we were able to achieve that in at least 94% of cases. But with the project came ongoing new challenges. I stopped this graph here at December 24 and it looks lovely, but actually then we saw another peak again in the beginning of this year, when we were finding it more challenging to manage the number of people requiring induction and the flow of the pathway again. So as we've carried on tracking this data, we were able to spot that quite quickly and then look into some of the reasons for that. Overall, we have seen an increase in the number of people having induction, and that's definitely had an impact on that flow of the pathway, and that's with some changes that have occurred around induction guidance within that time. We did a little bit of a deeper dive in our own data about this particular period in the early part of this year, and saw a big shift in the main indications for induction for us here at Medway, for which we saw a big rise in the number of inductions that we were doing around gestational diabetes. That's led to some more work with our diabetes team, looking at their guidance and criteria. And one of the things that has been a factor is that we had changed over to home GTT testing, which has resulted in a much higher number of people being diagnosed with gestational diabetes. So there's another whole piece of work that has come off of this piece of work. So although we were making progress, as I say, new challenges have sprung up along the way. The other thing we really wanted to do on the back of the process mapping exercise was to really look at the communication aspect of our induction pathway, because that had come up really strongly as one of the sources of dissatisfaction for our service users. We wanted to develop some good written information about the induction process and also to help people with their decision making. So we worked with our MMVP and developed an induction of labour Padlet. We use Padlets quite a lot at Medway as a digital information resource alongside paper leaflets as well sometimes, but we find it really useful to be able to keep them up to date. So with our service users in the MMVP, we developed our Padlet with information about what the induction of pathway involves, what to expect, frequently asked questions, various things like that. And we also looked at our top 6 reasons for induction of labour and have provided some more information in the Padlet about those reasons, specifically why induction is being offered, and we've laid it out using the brains template. So explaining for each of those reasons what would be the benefit of induction, what might be the risks of induction or the risks of declining induction, what are the alternatives to induction, and encouraging people to think about what's important to them. So our feedback since those changes in the pathway has been really good. We've seen a massive drop in induction complaints relating to induction, where that was before came up in feedback from all different directions and in the complaints, and was a theme in clinical instance, which it no longer is. So it was great to have some service user feedback that they have experienced improvements there, particularly people that had already been through this pathway previously before the changes that we'd made. So some of the positives about the project: we have had really good staff engagement and support from our senior team. There was a shared commitment to want to make improvements to this pathway and to make it be a really positive part of our service. Involving our MMVP and service users from the start really helped us to understand what the issues were from all different perspectives. Where we thought we had a good understanding of what the issues were, we were only looking at them initially from the clinical perspective, and that was really good to do that process mapping exercise and make sure we had that sort of full 360 view. Recruiting our lead induction midwife has been crucial to be able to proceed with all of these changes, and frankly I'm not quite sure how we are managing it without somebody in that role, and we have been able to secure that as a substantive post based on the progress that we've made through the project, and to be able to sustain some positive change. But it's not without its challenging. We've seen ongoing evolving picture of induction locally and nationally in terms of the number of people requiring induction and the indications for that. We're not really set up as a maternity service to deal with that number of people who need to be in hospital for a prolonged period of time. And although our induction rate is about 30%, if you take out the elective caesarians from our birth rate, actually the people that are planning to have a vaginal birth, the proportion of them that are being induced is actually much higher than 30%. We've tried to make sure that the project has been really data driven, so that we're constantly reviewing what are we doing, what impact has that had, is that working, what do we need to change, and that has been really powerful, particularly when we've been asking for more resources to support the project. But we have had a lot of difficulty being able to get some of that information from our digital maternity record, which is currently Euroking, hopefully not for much longer, because we found that that really challenging. Even just a question on Euroking which asks about the onset of labour, was it spontaneous, induced or no labour? And we discovered early on that lots of people who'd been on the induction pathway but not got successfully into active labour were being put down as no labour, which means that they weren't being counted within the induction numbers. So there's lots of things that we've sort of found along the way that have helped us to understand the pathway better. It's no surprise that the midwifery staffing has a profound effect on us being able to run this pathway properly. We have got to a point now where we have almost fully recruited, and we only have a 5 whole-time equivalent vacancy, where previously we had a very high vacancy. But even with that vacancy, that significant drop in those delays that I showed on an earlier graph happened before we were able to make particular inroads on our staffing vacancy. So we know that that is linked to the changes on the pathway, not just to having more midwives, but obviously having more midwives always helps. And the quality improvement projects take time, and as I say, we started this in 2023 and have completed that first part of the project, really focusing on the delays in bringing women in for induction, and are now looking at the next phase of our project, which we're currently in, where we've really focused on the delays after induction has commenced, one of those other sort of points in the journey that I mentioned. And our bigger challenge now is less about bringing people in and more about the bottleneck that happens between the antenatal ward and delivery suite. So at Medway, our primary induction of labour agents have been cervical ripening balloons and PROPES. And when we looked at our data, about 50% of women who were having PROPES were requiring a second dose, which meant, I don't know why this wants to restart, which meant that they were spending quite a prolonged period of time on the antenatal ward. So before they've even got into labour, they might have already been an inpatient for at least 48 hours. And PROPES actually isn't licensed for a second dose either. So we are currently trialling a different primary induction of labour agent, and we're currently trialling Prostin gel instead of PROPES, and we're just a couple of about a month into that now. We've looked at some of the aspects of our inpatient pathway, and we actually have an antenatal ward, and we actually didn't have specific ring-fenced beds for induction. We used to have an induction of labour bay, which was 4 beds, but actually over time that actually isn't enough for our induction of labour pathway. So we've had to review how we organise our antenatal ward to be able to have enough beds allocated for induction. And we've re-looked in our guideline about when and how it might be appropriate to use our midwifery-led unit that's co-located for some women on the induction pathway, depending on their reason for induction and whether or not they require oxytocin, which obviously can only be done on the delivery suite. But it has meant that that has still been an option for women being induced for some reasons, who then go into labour either after having their waters broken or after their first induction of labour agent. So that's where we are at the moment. We're currently in this point of phase 2 and hoping to be able to continue to make improvements to that pathway and improve the flow for induction and communication on the induction pathway locally. Any questions?
Thank you so much, Michelle. That's a fantastic presentation, and really kind of showcased not only the methodology of QI. You know, anyone that knows me knows that I love a process map as well. And seeing that, I can see a few people nodding and smiling. You know, the fact that you had some funding to go with that project, and that SPC chart where you showed those initial improvements, fantastic. And just talking about the ongoing process of QI, so you kind of solve your initial problems, that throws up other challenges, and then you kind of carry on with your cycles as you move through. So really fantastic work. Thank you so much for sharing. Any comments or questions from the floor, please? Grace, would you like to come in?
Hiya. Yeah, it would be really interesting to know, because I think the point that you raised initially was the definition of delay in induction. We've obviously all got our own projects ongoing about making sure that delays are managed appropriately. Do you know what you would define as a delay once the induction process has been initiated? Do you have a time frame for that?
So we've been looking at the delay in somebody being transferred to delivery suite when they're ready to be transferred to delivery suite, usually for ARM, but sometimes if their waters have broken spontaneously during the early parts of the process, they're going across for augmentation. So we've set that as more than 6 hours from when they're ready, and we're monitoring more than 6 hours, and also monitoring if it's more than 24 hours, because it is quite often more than 6 hours.
Yeah, I'd be keen to know from others on the call as well whether 6 hours is the kind of general consensus for that parameter, because at Tunbridge Wells we monitor a few different parameters, but 6 hours is one of them as well.
I think it is really important for us to be able to compare like with like between one unit and another, and like you say, we've all got our own different projects going on, but often we're measuring slightly different things and it's hard to compare.
Yeah, thank you, Michelle.
Gemma, did you want to come in on that?
Thanks, Michelle, for that. Yeah, like Grace has already mentioned, we all have sort of an induction of labour quality improvement project going on. I was just interested, Michelle, to know, with the ladies that exceed that 6-hour delay, do they then have an obstetric review? Is there sort of a reprioritisation of the inductions? Is the unit kind of is the unit assessed in terms of what can be done to try and improve the flow of patients from, say, delivery suite to postnatal to make room for the inductions to come over? Is there that kind of obstetric input?
Yeah, absolutely. And as I say, this is the part of the project that we're working on at the moment. So anyone who's on our antenatal ward has a daily obstetric review, and we have an obstetrician at our twice a day huddles at 10 in the morning and 10 in the evening, where we review all of the women on the list. Obviously not reviewing them face to face, that's reviewing the list as a summary and how they are being clinically prioritised. And we have a tool that we use with a number of prompts that actually I think I can't remember exactly where that came from, something in the southeast region, but with a sort of series of prompts that we use for exactly those things that you mentioned, trying to understand where is the delay. Have we not got enough staff in the right place? Is it that we're bed blocked on one of the wards? What are the things that would make a difference? And we're just trying to make sure at the moment that we're feeding into that, at what point we should consider whether we need to ask for help from other units, so that we've got some consistency around that, because at the moment that's a bit variable with individuals making that judgment themselves.
Thanks, Michelle. And I don't know if I missed it, but with your ladies that have already had SHROM outside of the hospital and then they come in for augmentation, do they start on the antenatal ward as well, or do they start on delivery suite?
Yeah, I didn't mention that actually, but that was actually another thing, sort of arm of the project at the beginning. We'd had a serious clinical incident in relation to someone with prolonged ruptured membranes that we weren't able to manage in a timely way. And so at the beginning of the project, we decided to separate that pathway out from the induction pathway. So previously, anyone with pre-labour ruptured membranes who either opted for immediate induction or expectant management and had been at home for 24 hours or whatever, went to our antenatal ward on this pathway. But now we have changed that, and they come directly to our delivery suite, and that's managed by our delivery suite coordinator. So if they opt for immediate management, they come straight to delivery suite. If they opt for expectant management, usually for 24 hours, then an arrangement is made with the coordinator to bring them in 24 hours later. And we've just audited that, and that's made a significant difference, both to the delays that are now rarely experienced on that pathway, but also to the outcomes for those births, with higher rates of spontaneous vaginal birth and less rates of infection.
And then they wouldn't be included in the sort of the list of ladies on the induction? No. Thank you. Thanks. Separate.
Thank you for the questions. And I think somebody mentioned some Southeast information. Yes, there was some comms in the document that went round. So if anyone hasn't had sight of that and wanting to have another look at that, do let us know. We'll circulate that. I think there were some definitions of delay, etc., in there to try.
We found that useful as a document, but it was kind of presented as a document that you would do for each individual person, whereas we use it as a tool to review the whole. Otherwise, you'd be filling the same document in
all the time.
You know, for all of the cases at the same point in time. But we have found that useful.
That's really good feedback. Thank you very much for sharing that. any final questions or comments before we move on to our next presentation? Let me just check the chat. Oh, we've got a comment. Yeah, we've got a couple in there. Yes, Grace will make sure that comes back out to you. And Grace also asks, how did you gain funding for your midwife?
Begging. Because it was just for a secondment, initially it was 3 months, and then they agreed to extend it to 6 months. We're just juggling things within our establishment, actually, to be able to just free up a bit of time that wasn't being used somewhere else at that time, and then we were able to put a business case for that to go ahead as an actual post.
So was that sorry, was that in addition to your establishment, or was that, like you say, just jiggling people around, maybe putting different people in different places?
It was jiggling people around for the secondment, and it was in addition once we've now got it secured.
Fantastic. If you don't mind, Michelle, I might take your email and get in contact with you about that. Thank you. Cheers.
Fantastic. That's what we like to see. This is not just information sharing, this is learning together and collaborating and networking. So yeah, that's great. Brilliant. Michelle, oh, sorry.
There's another question in the chat, but if we've run out of time, perhaps Michelle could have a look and answer.
Yep. Okay. Hayley's asking, when there are delays of more than 6 hours, where an individualised plan of care is documented, and how often, by who? So where is the individualised plan documented, how often and by who, if there's a delay of more than 6 hours?
So I don't know that we've got this bit quite right yet. I don't know why my computer wants to keep restarting in the middle of this. I'm not sure that we've got this bit quite right yet. And as I say, this is the part of the pathway that we're currently focused on. At the moment, we have, as I say, an antenatal ward round every day. So anyone that is seen individually on that ward round who's currently an inpatient would have that documented in their notes. But what we've been working on in the project is that review of any delay and like an actions coming out of that, so that we've got evidence of what actions have been taken when those delays have been identified and who needs to be seen individually.
Brilliant. Thanks, Michelle. Do carry on popping your comments and questions in the chat, and Michelle, if you're able to stay on and pick up those, if not, we can forward them on to you. Thank you so much. Look forward to hearing. Do come and let us know how you get on with the next phase. Now I'd like to move us on to Catherine White, who's a obstetric and gynecology registrar. She's going to come and talk to us about the decision to delivery interval, a CQC story at Maidstone and Tunbridge Wells. Over to you, Catherine.
Thank you. So it's another delay story from us today from Maidstone and Tunbridge Wells. So we're looking at the decision to delivery interval especially for our category 1 and category 2 caesarean sections. Can you move the slides for us? Thanks. Next slide. Brilliant. So this all comes off the back of a CQC report back in August 2023. We were at this point rated as requiring improvement. And so we had a look into this, and in section 29A, they stated that we weren't fulfilling the requirement that our category 1 caesarean section should be delivered within 30 minutes. Looking into our data, it was recorded that 42% of our cases from April to July in 23 did not meet that category, and that we were delayed contrary to the RCOG guidelines from this. And our caesareans, our category 2s, were also not meeting this and not hitting the target time frame of 75 minutes. Next slide. Next slide, please. Thank you. So they reported the reasons for this, and they looked at the initial delays. And the first one that they looked at was the lack of a second theatre overnight, especially lack of theatre availability and staff, and overrunning elective caesarean section list. And they're saying that the acuity of their service wasn't meeting this standard, causing harm to women and babies. So when we looked into this a bit further, this actually showed up 2 separate issues. We've got compliance within the category 1 and category 2 caesarean sections, and access to second theatre. Now, there's some overlap in this, but when we took a deeper dive, next slide, it wasn't the whole story as this suggests. So we investigated into it. I don't know, and one more slide again, please. And we found that looking between December and February 23-24, there were 33 delays identified, but actually the use of the second theatre was only a reason for 6 of those cases. Sorry, can you go back a slide for me? I've been on one too many. We looked at there was a variety of other delays spread fairly evenly across. So obstetrician being at another emergency was one, challenging cannulation. So we get them to theatre, but we've got no cannula in place. Translation services, we use language line, and often there's a delay either getting through to them or getting the required translator up. And failed epidural top-ups and need for a spinal. So if looking through all of this, there's a full MDT list of reasons here as to why our delays are happening. It's not just one thing, such as a lack of theatre. We then looked a bit more closely, I'm sorry, next slide, onto the times that this occurred, especially for the category 2. So this kind of set of data, the red indicates when there's a breach and blue is when it's compliant. And as you can see, both morning and evening, there is a much bigger time breach around the times of handover. And so we're looking into why this has been happening for us. I mean, I'm sure we can all come up with a list of reasons as to why there's always delay at handover, but it was quite stark to see that in place when we always speak about handover and things not delaying. Next slide. So we started off by doing a walkthrough and trying to figure out what was going on and why these delays were happening. We did an MDT simulated patient journey, and we got the whole MDT involved. So we got theatre staff, we got anaesthetics, we got the midwives, and we got the obstetricians walking through a case as to what delay was happening at each point. And it was quite interesting that some of the things that were happening during this time were the physical moving of the patient was a delay. So we weren't actually getting them from their room into theatre because of some communication issues that were happening at that time. So one of the small changes we made at this point was saying, actually, as soon as the anaesthetist has seen the woman, we can move to theatre. The theatre team will be coming. We don't have to wait for them to feed back to go from that point of view. Next slide. And then we had a talk as part of the team and listening to what was going on. And one of the big things that came out that there was no clear understanding of the categories. So we're expecting everybody to know our categories. So we know Cat 1 should be delivered within 30 minutes, but actually the theatre staff don't necessarily know that. And then there was also talking more around the category 3 caesarean sections, was there's established kind of culture that we can leave a category 3 caesarean section until office hours. So we can leave them overnight. Even if we want to call it at 10 o'clock at night, we can leave them till 9 o'clock the next morning. Next slide. So first of all, what we started off by doing was reinforcing the timings of the category 1 and 2 sections. So we reinforced that 30 minutes for Cat 1 if it's an immediate threat to life, and then 75 minutes for Cat 2, so if there's any fetal or maternal compromise. And it was talking closely with our anaesthetic and theatre teams to look at barriers to care and why we weren't getting them in these cases. We then reintroduced and redesigned the emergency section booking form. So again, highlighting these timings so that everybody was aware, because we have turnovers of staff, we have different staffs in theatre, so that everybody knows the categories and what the need is and how fast we need to move. We put visible target times around on the labour ward board, and we've included all this information again in all of our fetal monitoring teaching so that everybody is getting exposure to these. We then carried out a further deep dive into delays and seeing if there was anything else that was coming up. And we started off an audit onto a prospective audit onto the caesarean section compliance and seeing how we were doing from this. We did further walkthroughs with the theatre team, and we updated the standard operating procedure for opening a second theatre so that everybody was clear on the reasons why and when we would open that second theatre up. Next slide. And we had a look at then again at the NICE categories, and actually looking at them, they're not set in stone. The NICE categories were initially intended as an audit standard, not necessarily a recommendation for practice. And looking at although we have these distinct categories, it's actually about a continuum of risk with these women. So things can change. Not every category 3 can wait the full 24 hours before it happens. And the time difference between 75 minutes for a category 2 and 24 hours for a category 3 is actually a big issue here. And it meant that potentially we were misgrading our categories in order to get them done at the appropriate times. And then we looked a bit more again, sorry, next slide, is understanding these categories. So category 1 caesarean section is an immediate threat to life for the woman. And it gives you a list of potential reasons. And it's saying get it done as soon as possible ideally within 30 minutes. A category 2 caesarean section is maternal or fetal compromise, which is not immediate life threatening. So getting them in as soon as possible, most situations in 75 minutes. And it's the category 3 is probably where we've had a lot of our issues. So no maternal or fetal compromise, but needs early birth. So that could be a woman who is 5 centimetres dilated and stuck at 5. You would technically, if the CTG is normal, fall into the category 3 territory. But if it's 2 o'clock in the morning, do you really want her to wait until 9 o'clock the following morning to have her caesarean section, labouring away and doing nothing? And this is understanding what's going on here, with kind of enabled us as a team to look at why we were potentially miscategorising some of these women in order to get them done. Next slide. That leads in again to our cultural misconception within the unit. And again, category 3 caesareans can wait until normal office hours. And we found that, you know, talking to the team, especially our anaesthetic colleagues who are often quite isolated at night, they don't want to do what they perceive can wait until morning overnight in case another emergency comes in. They've got another anaesthetist, but they're covering CPOD, so there's no guarantee that there's backup if something else comes in. Again, we were looking through different reasons from NICE for this, and discussing with our colleagues about the continuum of risk and saying, actually, we need to upgrade some of these category 3s. How can we do this without affecting our category 2 compliance? So next slide. We asked, can all category 3s wait until office hours? Well, no. As obstetricians, we generally recognise that we've got that continuum of risk. And we would overgrade the slow progress without maternal or fetal compromise to a category 2. However, in times of high acuity, you then have somebody has to come in at a faster and be delivered quicker. And we would prioritise that fetal distress over slow progress, again, leading to us having decision to delivery delays. And so that, again, was another thing causing our delays that we recorded. Next slide, which raised the question, and we're going to jump on the slide again. Was all the data that we were getting from E3 accurate? Next slide. So we went through a data cleansing exercise to look at the clarity around our category of caesarean sections. So we had at least 2 obstetricians looking through, and if there was any adverse perinatal outcome as a result of delay, they would then look through the data, back through the data for those, were those patients appropriately categorised? Next slide. So this led us to the proposed solution of a separate proposed solution for the category 3 section stigma. So we've incorporated a subcategory into our category 3s. So it was discussed throughout the labour ward MTT. So we had anaesthetics, the theatre team, and the obstetric and midwifery team on board. And we have, next slide please, agreed for a new categorisation of our category 3 caesarean sections. So category 1 is still 30 minutes, category 2 is 75, and then we have a 3A, which is decision to delivery with 120 minutes. So we've got a little bit longer. So these are ones we recognise can be pushed back, but can't wait till morning. The most of them are normally intrapartum, and they're already on labour ward. So they need to happen within kind of a shorter time frame than a category 3 would otherwise suggest. They have to have no maternal or fetal compromise in labour. And the examples we've got are for slow progress in labour with no suspected fetal hypoxia, severe stabilised preeclampsia where delivery is required, or breech in labour as long as they are not there's no other compromise. They must be done as soon as possible, including out of hours, as long as they're not delaying a category 1 or category 2 caesarean section, so prioritising appropriately. If the DDI is longer than 120 minutes, it must be escalated to the consultant or out of hours to the senior registrar for a clinical review to make sure the categorisation remains appropriate. It doesn't need up categorising and that they can still wait. So ensuring there's still no signs of hypoxia, no CTG changes or other concerns. Next slide. 3B is our other category. And that can wait to the 24 hours. So it can wait until daytime. And those are things like failed induction, an SGA who's not suitable for vaginal birth, a stable preeclampsia, a breech with Schwann but not in labour. So this one should be avoided out of hours. And so we've put that times as between 7 o'clock in the evening and 8:30 in the morning. And if appropriate and we can add those onto the elective list as well, if there's space. If it looks like they're going to be waiting for longer than 24 hours, they must be reviewed by the obstetric consultant to make sure that the category is still appropriate and they don't need to be upgraded or changed in any way. And obviously there's sometimes exceptions to all of these and everything. If a category 3 is being performed out of hours, then we need the on-call obstetric and anaesthetic consultant to be on board with it. It's a joint decision with them as we're both managing the risk of this patient. Next slide. So this shows of what's happened as a result of all of this, and it's looking at how often we are now meeting the targets. So you can see our category 1 now is hitting nearly 100% of the time, with a slight dip in July, but we are most of the time hitting 100% of appropriate categorisation happening within the 30 minutes. Category 2 has also improved, and at the last count we were at 96%. So overall we've got a general upward trend improving our kind of time to delivery. Next section. So we found that improving through kind of the teamwork and the proper data review, our compliance has now improved. However, as you can see from that graph before, there is still room for improvement and still room to get it better. Next slide. So we are now rated as good from the most recent CQC report. Our caesarean section compliance was no longer highlighted as a concern for us. So we have kind of improved and got much better from this point of view. Next slide. And then Ollie, who wrote this thing, has given us some top tips for how to improve things going forward. So tracking and making sure we're following our compliance. So just because we're now good, we should continue to be watching our compliance, choosing our trigger points. And if we're performing poorly, identify it and get on to manage it quickly, not let it get to the stage where we're missing 42% of our Cat 1 caesarean sections. Really important through all of this was going to the shop floor and talking through the challenges. So we all think it's just one thing, say opening the second theatre, but actually when you get the theatre staff there, you realise a lot of our delays are purely patient movement as well. Hence the change that if the anaesthetist is seen, we can move. We don't have to wait, otherwise there's a lot of back and forwards from each other, and actually just get the patient round. And then acting, making sure make the changes and then see if they're working, and reviewing and ensuring improvement going forward to improve kind of safety of women and the babies as well. Next slide. So going forward, our plan is to try and continue the excellent MDT work on labour ward. We all work together really well and ensure that keeps going forward. Ongoing work around theatre cases at handover time. So that's, as you saw from the earlier slide, that's a big sticking point for us. Everybody's tired towards the end of the shift, so how we can start improving those delays. And then ensure that all these changes that we're putting into place just become business as usual. So you know what your categories are and carrying on moving forward. Thank you very much.
That's fantastic. Oh, sorry, thank you, Catherine. Absolutely fantastic presentation. Another quality improvement project, which is, yeah, I think it shows some really positive results there. I love the MDT simulated patient journey. I think that's great, doing that together as well. So you're not only understanding each other's roles, but understanding that whole journey as well. And I think you've picked up some really important points about the clear understanding of the categories and the importance of that, and the continuum of risk as well, particularly like that. Data challenges, I think everybody's having those data cleansing challenges as well, and I think that's something that's we've got to kind of get right as we go forward, because we're moving towards this digital world. And I love the top tips as well. Yeah, track, talk and act. Absolutely brilliant. Thank you. Any comments or questions? Thanks, Sean.
Hi, thanks, Catherine, that was brilliant. Do you know how you're going with your 3A categories in terms of 120 minutes? Is that working as well?
I don't actually know what the data is showing for that yet. I'm not sure we've done much of a collection from that point of view. I personally haven't used it particularly very much yet, but everybody's much more aware of it, so I'm hoping it will be pushing through.
Thanks.
And we've got one in the chat from Lauren saying thank you for a really interesting presentation. Is she? Can you please have send her your guideline? I think she's interested in having a look at that, if you're happy to share.
Absolutely, we can send that.
Brilliant, thank you. Some love there for you. Any other comments or questions? Michelle?
Disappeared off my screen.
Oh, yeah.
Some nice
She's got her hand up.
Maybe I'm back.
Oh, there she is.
I was just going to comment, just as just really interesting to me that both in my presentation and yours, Catherine, these kind of markers of how we measure ourselves and the difference between how we do those things in each unit that make it really hard to compare the like for like. The things that you listed in your 3A category, I completely follow your logic of what you've done there. In our unit, anyone in labour who has a decision for a caesarean would automatically be considered a category 2. So I find it really interesting that we've got these kind of parameters, and then it's very hard still to compare because things can be interpreted slightly differently. We have a bigger problem between our category 2 and category 1, that our theatres team get cross when we ask for a quick cat 2, which means that it doesn't quite meet the cat 1 criteria, but we're concerned enough about the baby that we want the baby to be born as quickly as possible, and they say, you know, this cat 2, we've got 75 minutes, and it's that continuum of risk that you talked about.
Yeah, and I think it's making sure that our theatre teams are kind of with us on that, because I certainly often ask for a quick cat 2, and I've never had pushback from the theatre team. They all go, okay, go, rather than anything else. I was like, otherwise I can put it as the cat 1 if you like, and they all then go, no, we'll go for the quick cat 2. So I've never really had pushback. But yeah, I found the same. I've come from a unit where all in labour would be classed as a category 2. But I think in a unit like Maidstone and Tunbridge Wells, we've got, I think, over 6,000 deliveries a year. So it's just too many in the number that we have to do. So downgrading it the other way has probably worked quite well for us.
Yeah, it's interesting. Thank you.
Thanks for that, Michelle. Grace, would you like to come in?
Yeah, I was just going to say, I think, you know, really the definitions that we're working towards are the nice, you know, categorization, and actually it's how everybody interprets those categories. So I don't think anyone's wrong to say that a category 2 would be anyone in labour, but actually when you read between the lines of nice, you can interpret it in any way, and I think that's how we've managed to introduce the 3A and the 3B, is actually by looking at that interpretation of nice and saying, well, if there's not immediate maternal or fetal compromise, then we can fit it into this category. So I think it's something that everybody will interpret differently. So I don't think there's a right or a wrong. It's what works in your trust.
Thanks, Grace. Any final questions or comments for Catherine before we move on to our final presentation? No. Okay, Catherine, thank you so much. Absolutely brilliant presentation. Thank you, and do stay on for the final presentation, see if there's any more comments or questions in the chat for you. Okay, so moving on to our final presentation, I'm going to invite Amber to come and talk about the Early Breast Milk Project. Over to you, Amber.
Yeah, hi everyone. I'm Amber Clark. I am the infant feeding lead at Oxford University, but I was on the infant feeding team in University of UHS in Southampton at the Princess Anne. And this is where this project originated and started during my time at UHS. And so I just give you that background because it makes a difference when I'm talking about this experience. So anyway, so that's me. I worked alongside Holly Green with Health Innovation Wessex, and she spearheaded all of this kind of the drivers, and I was the clinical lead. And so we worked alongside one another with this QI project. But the way in which it came about, it's an early breast milk project. And I had the great privilege to be part of the Wessex Matt Neo Leadership Optimisation team in 2023, I think. Yes, it would have been 2023. And I attended a sharing event where a patient experience was shared. And this is Harry, and he is Katie's fourth baby. She was booked at UHD and then was transferred to a Wessex hospital, regional hospital, when Katie went into preterm labor, and Harry was born at 26 weeks. So he was transferred within Wessex due to clinical need. And what ended up happening was that Katie had breastfed all of her other children, and then suddenly had this 26-weeker who she was exclusively expressing for. And what happened was that while she was expressing for him, she developed mastitis twice, and the second time was so bad that she had to be admitted to the general hospital for IV antibiotics. So that means she was separated from her baby, she was separated from her other 3 children, and it's had a great impact on her and her family. She did present overwhelmingly positive journey, but it was full of praise for all the services she engaged with. However, she did describe some areas for improvement, particularly around her experience with expressing breast milk. We all know that early breast milk is hugely beneficial for all babies, but with additional benefit for preterm babies, as it reduces the incidence of NEC, and it forms part of the PRIM 7 and the peri-PRIM bundles, and is in theme 5 of Saving Babies' Lives. And so when I was attending this event, I was thinking in my head, I know what to do about this. Like, okay, and I just immediately, my brain started going, and that's how this accidentally started. So what I did was, the problem is that currently there's low level of evidence surrounding or low level of knowledge of the impact of correctly fitted flanges, which the flange is the part that attaches to the breast. Essentially, that should be sized appropriately for the individual person. It's not one size fits all. And so oftentimes different sizes aren't available on the wards, or if they are, they're much too large. And we were then requesting women to purchase their own. But we do know that when we have got a correctly fitted flange, that this can help increase colostrum and milk output. It can decrease pain and swelling, and then reduce the risk of developing mastitis. So part of Health Innovation Wessex Matneo development coaching program, we identified that breastfeeding was an area that needed to be addressed, and that early breast milk. And so after I had attended that event, that learning event, I then went on to make sure, before I started doing anything, making any changes, I needed to make sure I was up to date with current evidence. And so I went and took a couple of additional courses, and realized that there was some new research coming out actually from America. And I thought, oh, this is interesting. And so I took a couple of extra courses from them. I took a couple of extra courses from another area, and they were kind of starting to say the same thing, that actually smaller, more, when you're measuring, you want to go more true to size to the nipple rather than adding lots of size, expecting that one size fits all. And so what I did then was I brought this new information on at UHS, and we decided to pilot different size flanges. And then from that little pilot, we found that we are starting to receive really positive feedback. And then we were seeing a massive difference in the milk yield and the comfort levels for the parents. So this is the information. It is a small pilot study, but it was published in November of 2024. So when we started this in 2023, we were kind of on the cusp. We knew it was coming out. We knew that it was there, but it hadn't yet been published. So we're kind of doing this in the hopes that we were getting it right. But when we started doing the project, it was so overwhelmingly positive that really led us to go on to I'll explain later, but share it widely throughout the region. Now, what this research found is that standard fit flanges, they had a significantly less milk output and less comfort when compared to the newer, smaller size fitting or more appropriate size fitting. And the paper concluded that flange fitting is a process that should be individualized to the patient and may require a trial of one or more sizes during a pumping session. Smaller sizes determined using this individualized process and starting with the nipple tip measurement may be used without compromising milk output or comfort. Now, there is the need for doing more research into this, and that is something I'm actually really interested in and passionate about, but this is what started everything. So within our early breast milk project toolkit, these were our drivers, our aims. We really were just at the root of it, wanting to improve equity of access of equipment for mothers with babies on TCU and neonatal units by April of 2025 across the Wessex region. We did receive funds from NHS Southwest England to spread the adoption of this project across Wessex. I worked alongside the other infant feeding leads for maternity and neonates across Wessex. And we met regularly, maybe, I feel like we met every month or every 2 months, but throughout 2024 to discuss the evidence, share our experiences and support the local challenges around procurement and getting those resources. We also had the MNVP guidance on that and support as well. But our primary drivers was within this toolkit that we developed was to update staff with evidence-based practice. So I'll talk in a minute, but and then we did parent education as another driver, and then access to resources. And then from there, you can see those secondary drivers. And so focusing in on integrating that education into training, making sure that it was available, for our themes of the months or things like that, and making it mandatory training. That's kind of mandatory that staff are needing to do this training. And so we actually recorded a webinar, and it is now on the learning hubs and on VLE and those resources as well. And so and then putting it in for induction for new starters, and then making sure that within our antenatal, so within parent education, we're kind of educating them antenatally, developing those teaching resources to support parent education, especially for those that are at risk of preterm birth, and then material for breastfeeding workshops. So making sure that this information is getting out proactively rather than reactively. And then obviously part of that is the support for women at the time of expressing. So making sure that we have digital resources or videos available to support mothers at the time of expressing. So I'll show you in a moment, but we created a professional video with a QR code, and it's put on all the breast pumps within the hospital, so that no matter what time of day, if that parent needs a refresher on how to optimize their expressing or make sure that things are going well, they can scan that QR code and watch that short 8-minute video again. Obviously, we want to make sure that the access to resources was available. So I recreated a measuring tool to correlate with the sizes that we needed that we had available on the unit, and then making sure that we had those flanges in a variety of sizes. So we did work with a local company to design and produce nipple fit measuring tool that's available in the ward areas, and that's going to be attached, you'll see in the next slide, on the pumps as well. And then we made sure that we are supporting the procurement process to ensure a range of flange sizes are available within each unit. So this kind of, I guess, our project goal and measurement, how we're measuring these things. Obviously, our goal is through training staff, educating women, and supporting trust procurement, that more women will have free access and equitable access to appropriately fitted equipment to support expression of breast milk. And this is going to contribute to a more positive patient experience. What I always tell people, especially those who are supporting families who are expressing exclusively for a baby that's in the neonatal unit or on TCU or for whatever reason, that is literally the only thing that they have control over for those families at that time. And so being able to support them to do the one thing that they have control over comfortably and well, and make sure that they're getting as much as possible, I think is a really important driver for this. Now, at least that's my goal. But this was measured, and it's still being measured by the number of staff that's being trained, the number of women accessing the educational video resource that was developed, and then obviously the number of stock items issued that are outside of the standard 24 millimeter or 26 millimeter stock. So how many flanges are we using that are not that 24 or 26 millimeter based off of this new research? It's measured by the qualitative feedback from staff that are trained, and then the qualitative feedback from women supported to express. And then we're also monitoring the increase in breastfeeding data captured in the Thames Valley and Wessex Neonatal Operational Delivery Network dashboard, and that is helping us to really see what's happening in the units that are adopting this and going full force. Okay. So this is just I developed a staff training video. It's me, and I have got real live videos. So the staff training, we want it to be not too long, so about 15 to 17 minutes, and have real videos of people expressing with the incorrect size and then expressing with the more suitable size. I wanted it to be not just this theoretical idea, but actually you could go and watch multiple different people expressing. So these are kind of the links of what we developed for staff training. And this is the patient information on the breast pumps. That's the one that's available to the parents via the QR code that's you'll see here on this breast pump. And these are the tools that we also developed. And we made these tools based off of the sizes that are available at the moment within the units with these different flange sizes available. And we've got it to where those tools are attached to the breast pump. So there's really no excuse to or hindrance for people to be able to be measured appropriately. It also is set up in a way that a family could actually measure themselves. So it wouldn't necessarily be staff dependent, but I would want a staff member to double check that measurement. Also, just to note, like, you don't need a fancy measuring tool to measure appropriately. And when you're measuring, you're getting a gauge or a guide. It's not necessarily exactly what you will go with ultimately. So part of this process for me that was a big deal was I contacted the manufacturer. So unfortunately, at this time of this recording and this webinar, the main pump companies they're not producing the smaller flanges that we are requesting. And so at this time, we needed to go to another source that was producing these that are compatible with the other kits. Or compatible with the other manufacturers. And so I went to them and I said, look, I want to bring these on to the NHS, but the pricing has got to be equitable to that of the pump companies, or you need to beat it, because I can't, we have to save money within the NHS, and I'm not going to be able to convince anybody to spend more money. So they actually came back and they actually are priced slightly lower than what the main companies are for their flanges, because you can buy larger size flanges from these other companies. But these are the smaller sizes. You can go down to 10 millimeters. And so essentially they worked really closely with me to develop appropriately priced information. Now, one thing that we have written a SOP for, which is a tester kit of flanges. So let's say that you really want to try a couple different sizes on this particular person, and I always tell people the breasts are sisters, they're not twins. And so one side might need a different size than the other side. And so this testing kit is made in such a way that you're able to actually try out the flanges on the pumping parent and make sure that you are using the most comfortable shield, and that you are using the one that is getting the most squirts and breast milk. So that I will say, just as a caveat, that in the well, it is about 2 years now, exactly 2 years of clinical experience using this new measuring method, I have only in one time in the probably thousands of women that I've supported with expressing, seen one person who truly needs a size 24 millimeter flange. So the majority of people fall into the 13 or 15 millimeter size category. And so I have truly only ever needed once the 24 millimeter. Okay, so this is where that research paper was really interesting to me, because that research, the pilot program study, was done from people who had already produced mature milk, and they were pumping from about 4 weeks of postnatally until about 6 months, and somewhere in between there during this pilot. So they weren't looking at early breast milk production. And something that's been amazing that we've seen is we know how amazing colostrum is for these babies, and it is that first milk that the body produces following birth, and we know that it's thick, it's nutrient rich, and it's just so crucial for especially those preterm babies. Now, I've got a little hack. So if you see here on the, I think it's on our left, that is a picture of a breast pump turned upside down. So anytime that someone is expressing, if you turn that pump kit upside down while they're pumping with colostrum, that colostrum is going to sit in the funnel, and you will easily be able to open up the back or pour out into a pot the colostrum that's collected, and it won't get lost. If you have it turned upright, it won't get lost going down the bottle. And we know every drop counts. So this is just a tip for you to kind of optimize as much colostrum. But I think what's been shocking to us is the amount of colostrum, even pumping from day 0, the changes in volumes that are able to be gotten pumping from day 0 with the correct size flange rather than the really large size, standard size. And this person came to see me. She had been expressing with a large 24 or 26 millimeter flange. And literally from one pumping session with a 24 or 26, I can't remember which one, to the correctly fitted, which I think she was a 15 millimeter. She literally pumped 5 mils previously for about 25-30 minutes with the bigger size. And then when we changed her over to the 15 millimeter flange, she pumped something like 25 mils. And that was at 48 hours post birth, which is shocking in my opinion, but it's just leading to some really cool anecdotal evidence of the impact this is having from day 0 for these families. The feedback we have when we're pumping with the correct size flange is not only are their comfort levels so much better, but they're also seeing visually that they're getting way more volume. And so on the right side of this, you can see that they're almost in some cases doubling or tripling their output of milk. And so for someone whose baby is on the neonatal unit or is on the TCU unit, who is having these volumes of top-ups, this is a way in which we can really empower those parents to be able to give everything they can to their baby. I'm not going to read through those, but the resources as well, from the feedback from staff has been really positive, and I don't need to go on with that as well, but it has been overwhelmingly positive. And then what are our next steps? So we want to continue to measure impact in Wessex. So maternal breast milk in premature babies has increased by 13% since we kind of introduced this project. We're measuring the impact of those donor and formula milk. So how are we decreasing our use of those and need to use those? And that's something that we're going to measuring. We're measuring or we're looking at how many trusts outside of Wessex, external to Wessex, are bringing this toolkit on. And so I'm supporting with that as well. But as of February 2025, So it has been accessed 4,422 times from February of 2025 to June of 2025, which is quite a large number of times that the toolkit that we have created has been accessed by external trust to Wessex. And then we're obviously promoting and gathering feedback on the toolkit from staff and families, and then hoping to do further research but on from now. And then Holly said anytime you're sharing this information with anybody, she'd love to have feedback coming in to see if we can improve it in any way, and just how to get a hold of Holly. And yeah, I'll leave it there. Oops, I can go back if you guys want me to, but any questions at all?
Thank you so much, Amber. What a fantastic presentation. Absolutely love that. And I've learned something new as well. The tip, holding the bottle upside down, that's brilliant. Does anyone have any comments or questions for Amber, please? Amber, I don't know if you want to stop sharing so we can see everyone.
Sorry, apologies.
No, not at all,
Yes.
not at all, just so we can see if people.
Of course.
Yeah. So Claire's put a lovely comment in the chat for you to say thank you for all your help. Fully implemented your work in Portsmouth and it's working wonders and making a big difference. If you don't mind me asking, I know you mentioned research and the fact that there's not much out there. Are you planning to write this up and publish as well?
I would really like to be able to start doing some research from day zero, formal research, but that is going to just take some time to get in with the right people, I think. But as it is, it's not publishable at the moment, but we do need to yeah, we would love to do that.
Thank you. Any other questions or comments for Amber? No, I think that's it. Can't see any hands up. Okay, thank you. So it's my pleasure to say thank you to all of the thanks, Sean. You can take those down now. Thank you to all of the speakers for today, to Michelle, to Catherine, and to Amber for their fantastic presentations. I've learned a huge amount. I hope you have too. Really showcasing the importance of MDT working, quality improvement methodology to really drive forward improvements in patient safety as we celebrate the World Patient Safety Day this week and the days tomorrow. I hope you've all got things planned within your organisations. Oh, Sharon, you had your hand up. Or was that an accidental hand? Accidental, no worries, no worries. Yeah, just thank you again for all of your ongoing efforts and commitment to improving patient safety in maternity and neonatal services. We will share these slides and the recording after the meeting, probably not today, but possibly tomorrow and definitely by the end of the week. We invite you to leave some feedback for us to help us make sure that these webinars continue to meet your needs. If you've got any suggestions for any future topics that you would like to hear from, or if this has inspired you to present on some of the work that you're doing in your local areas, then please do get in touch, and we'll send you all out attendance certificates for your CPD folders as well. I think our next webinar is going to be in November as we celebrate World Prematurity, well, maybe not celebrate is the right word, but it's World Prematurity Day and Week, so we're going to be focusing, I think, on neonatal projects. So it'd be great if you've got anything you'd like to share for that. Sean, have we got the date for the next one, please?
Yes, it's in the chat. It's the 18th of November, 11 to 12:30.
Brilliant, thank you so much. I look forward to seeing you then, and do get in touch. Thank you so much, everyone.